In this video, we'll talk about infectious disease relating to dermatology. So first, we'll compare and contrast erysipelas and cellulitis. Erysipelas is a superficial skin infection that'll be well demarcated and it'll be bright red. It has a rapid onset and spread versus cellulitis, which is a deeper skin infection. It has an ill-defined border and the course is a lot slower in progressing. Next, we'll talk about HPV, and this can cause plantar warts, and these are spread from person to person through skin-to-skin contact. And to diagnose this, you can do a punch or a shave biopsy. To treat this, you can use salicylic acid, or you can use liquid nitrogen, but that can cause potentially hypopigmentation to the area. It's important to counsel patients that it can take about 2 to 3 weeks to see any results, and it's important to tell them to continue taking the medications for about 1 to 2 weeks after the warts have been resolved so that they can prevent reoccurrence. If there are anogenital warts, you can prescribe topical imiquimod, and the way that works is by inducing local cytokines. Next, we'll talk about varicella. To treat this, you can give valcyclovir or acyclovir. Both work, but valcyclovir is preferred because you can prescribe it for a less amount of days. And it's important to remember that the drugs will only really work if the patient comes to you within 74 hours of the rash onset. These patients can also get postherpetic neuralgia, and to treat this, you can do TCAs, pregabalin, gabapentin. Let's say a parent brings a child in after they found out that another child in the class had chickenpox. If the child has already had chickenpox in their life or already gotten 2 doses of the vaccine growing up, then they don't need any post-exposure prophylaxis. But if they haven't had either of those scenarios, then they should get the post-exposure prophylaxis with the vaccine within 5 days of the exposure. Let's say someone has chickenpox and they ask if they're contagious or allowed to go around people. So until all of their lesions are crusted over fully, they are still contagious. So if they have to be around people, you can recommend covering up their lesions because it's spread through direct contact. Next, we have Molluscum Contagiosum. This is also spread through skin-to-skin contact, and this will usually spare palms and soles. For this, it's highly associated with HIV, so it's important to check patients for that. Next, we have scabies. Scabies is a really itchy rash between the skin folds. And treatment for this is oral ivermectin or topical permethrin. You can diagnose scabies by doing skin scrapings and looking at it under a microscope. Kaposi sarcoma will look like this and is associated with HHV8. Next, we can talk about the tinea infections. So tinea capitis, treatment for this is oral griselfovin. Tinea infection of your nails is treated with oral terbinafine, and griselfovin can be a second-line treatment. Tinea versicolor is associated with Malassezia furfur. Patients will present with hypopigmented spots on their skin that'll be itchy and that won't darken when they're out in the sun. Impetigo is most commonly caused by Candida. Risk factors for this include obesity, diabetes, and treatment for this is topical antifungal, and it can be diagnosed by a KOH stain. Impetigo is most commonly caused by Staph aureus or group A strep. These will commonly present with a honey-crusted lesion. Treatment for this is a topical antibiotic like mupirocin. A complication that can occur is PSGN. Next, we have Paronychia, which is a bacterial infection of the nail fold. Treatment for this is draining the abscess and giving antibiotics and also soaking their finger in warm water. Pityriasis Rosea will occur after a viral infection, and this will present with that Christmas tree pattern rash, and this will resolve spontaneously so you don't have to do anything for it. Erythema multiforme will look like a targetoid rash, and this is very commonly associated with HSV, and it can also be caused by taking certain medications such as penicillins. And there's a couple different erythema rashes that can kind of get confusing, so let's review them now. Erythema multiforme we just talked about. Erythema nodosum will be painful nodules that occur most commonly on the shins and are associated with IBD or RA. Erythema marginatum is associated with rheumatic fever. Erythema migrans is associated with Lyme disease and will have the bullseye appearing rash. And lastly, erythema infectiosum. This is associated with parvovirus B19, otherwise also called as Stiff's disease. This is when you'll have that slap cheek appearance